My name is Bertrand Campoer, GCTA Board Chair. I'm from Cameroon and welcome on this session. The most effective intervention available to reduce the risk of latent TB infection progressing to active TB disease is TB preventive treatment, TPT. Globally, the uptake of TPT remains low due to the deep knowledge gap. The progress toward the very ambitious UN HLM target has been slow to start with. Additionally, in 2020, the COVID-19 pandemic reversed some of the gain that we were just starting to see in TPT uptake in the country. Only 29% of the 30 million people targeted were provided TPT in 2018-2020. One of the reasons of this lack of meaningful engagement with affected communities members. The medicalized approach to TB has largely alienated the affected communities member. This gap can only be bridged by bringing the community at the center of preventive treatment plan and equipping them to advocate for TPT. The GCTA collaborated with WHO CRO and WHO AFRO to conduct 2 regional level workshops titled How to Protect Ourselves from TB, Advocacy Roadmap TB, Preventive Treatment through Community Engagement. Among the participants were senior activists representing cross-sectoral community initiatives, TB community, people living with HIV/AIDS, transgender community, sex worker, drug user, and people from susceptible geography. This diverse gathering had a single goal to equip themselves with the best know-how about TPT to benefit their respective community. The theory and practice-based structure of the workshop allowed the participants to equip themselves with basic clarity on TPT. This was followed by drafting an individual action plan which allowed to put the TPT framework in context with their real-life on-ground challenge. This Community Connect session highlights some of the learning that 4 of the participants have had in this workshop and how they have been able to implement the same in their country.
Hello, greetings to all. My name is Archana. I work with GCTA, the Global Coalition of TB Advocates. In the next few minutes, I'll be sharing to you all briefly about our experience on what we have done on TPT. TPT, as we all know, is TB preventive treatment, and it is one of the most effective interventions that is available with us. And TPT is also one of the key interventions recommended by the WHO to achieve the NTB strategy targets. The slide over here is just showing us the global targets, which was committed by the world leaders on the first UNHLM meeting in 2018. And as it can be seen over here, I mean, except for one, almost all the targets are not achieved. I mean, we are lacking far, far behind. So from our experience, what we have learned is that globally, the uptake of TPT is very, very low because the knowledge level is also low, and also the engagement of the community is also, I mean, there is no meaningful engagement of the community. So in order to address these gaps at GCTA, what we have done is we have developed a community-friendly brochure on TPT in the year 2019. And this brochure is now updated, and it is also available in the 8 more languages: French, Nepali, Hindi, Thai, etc. I mean, this was updated, and the translation of this further led us to reach out to more wider audience. And also, we, as I said earlier, that one of the main gaps is also is that there is a very low knowledge on TPT as such. So in order to build up the capacity of the knowledge and the skills on TPT, what we did was we conducted a workshop, 2 workshops actually we conducted at a Southeast Asia regional level and at Africa region. So this workshop was actually, I mean, it's different from the other workshops in the sense that the participants were already communities leaders who are doing wonderful work at their own respective field. So we invited these community leaders, and it was a knowledge building workshop. Of course, the first session was, and it was a 2 days more. So the first was all to update the knowledge. We had a knowledge building session. We discussed about the latest guidelines and the treatment and the knowledge available to us and the research which is going on TPT. But it is different in the sense that we also discussed along with the participants who were the representatives from drug user networks, the PLHIV network, the sex worker networks, and the transgender and the community leaders who have done good works in viral hepatitis program and all. So we, at the end of the workshop, we came up with identify each of the participants, they identified the advocacy issue and the plans, and they developed costed advocacy plans on how to take forward that issue in order to increase the uptake of TPT at the local level, at the community level. So same thing, the first workshop was done in collaboration with ITPC Global and WHO CERO, and it was, we had about more than 25 participants. And in the second workshop, which we did for the Africa region in collaboration with WHO Africa, we had about more than 30 participants. So, and in India, we also did a knowledge building session along with the Touch by TB, which was it was a virtual session which was attended by more than 90 participants. I mean, that was also a response to the need of the community at the field level, that they wanted to know more about TPT. So at the moment, what we have now is about 50 plus advocacy costed advocacy plans. Some of the plans have been already implemented by the participants, but some are like, we are working together in order to, mobilize the fund, because because we have not been able to implement the advocacy which was developed, the advocacy plan which was developed, because the resources has been a big issue, and we are working with the partners together in order to mobilize the fund, because to do advocacy also we need fund. So the way forward, the lesson learned for us is that, we just have started doing things and we're still continuing to do things, but a lot more needs to be done. We need to continue doing advocacy to increase the uptake and the access. And but compared to what was happening like before 5-10 years, we can see that in the recently there has been the scale up of TPT at the country level and also at the regional level. So when the programs are being scaled up, we know that certain quality issues will always be compromised. So we strongly feel that the CLM, the community-led monitoring aspect or the approach should be integrated while planning the TPT scale up at the country level or at the regional level or at the global level. And we have to continue doing to generate the demand generation for TPT at the local level and at the country level. Thank you.
Greetings, I'm Edina Tembo, working for Coalition of Women Living with HIV/AIDS in Malawi as the Executive Director. My topic is on increasing TPT uptake in women living with HIV, learning from Malawi. How we did it, we made sure that we provided knowledge to the communities, especially women living with HIV in their support groups, and advocated for policy change, as well as accessibility and availability of commodities. At community level, we trained women living with HIV in support groups on TPT as peers and champions. We train them in treatment literacy and counseling so that they know the benefits and also the reasons why people living with HIV need to take TPT. We train them on monitoring, adherence, and completion of TPT. We also train them in community-led monitoring for follow-up for those who have interrupted treatment. We worked with media to raise awareness so that we reach out to the wider scope. And we made sure that we recognize the champions of TPT who completed to motivate others so that they get to initiate on TPT. We involved women living with HIV in community mobilization. At facility level, we made advocacy for integration of services and scale up of TPT to all districts. We built capacity against stigma and discrimination so that all the recipients of care are welcomed and receive treatment without discrimination. We included indicators of TPT in the National Community-Led Monitoring Program and participated in networking and technical working groups of various TP and TBCSO networks. We also made key informative discussions on 3HP so that people are aware of the benefits of 3HP. And we involved parliamentarians and traditional leaders so that they can also work with us in mobilizing and creating demand for increased TPT uptake amongst women. The challenges which we found was rolling out of the TPT, especially 3HP, due to limited quantities which were procured in the country, and the discovery of impurities in the first batch which was delivered, and the eligibility criteria which restricted 3HP to only newly initiated on ART. Pregnant and breastfeeding mothers were not eligible. Household contact definition and tracing was a challenge. Low acceptability of TPT, especially to those who experienced side effects. We learned that working with the community is a major game changer because the communities help in mobilizing as well as creating demand. And working with women living with HIV in the support groups helped us a lot to increase uptake and demand for TPT in Malawi. Thank you very much for your attention. These are the photos of some of the members who were doing the community mobilization. Thank you.
My name is Stephen Anguba Shikoli. I'm the National Coordinator Network of TB Champions in Kenya. Indeed, communities take reign in matters to do with TB at the community level. Communities are very critical and they play a critical role for creating awareness, supporting adherence, and preventing the spread of TB. As we all know, TB is now more of a social issue than a medical condition. Therefore, engaging TB-affected communities at the grassroots level is the only way to find and end TB. We are never safe until everyone is safe. We need access to preventive treatment for everyone. Through several online trainings for TB championed by our global partners, such as GCTA and Treatment Action Group, we are now able to increase demand for TB preventive therapy in the country from a point of knowledge. We are now able to support members that are on TPT. For the world to be successful in UHC, they must put the community at the center of any intervention. There is no success without community. Meaningful engagement of the affected communities means, 1, funding community-led intervention that are conducted by TB-affected communities. Each dollar you invest in the community, I assure you that you are more to get more returns. Number 2, supporting community participation in any TB policy development process, not just policies for people, but we need to be engaged at policy developments. Engaging affected communities in research and development process, from formulation all the way to implementation, is very important when we talk about community engagement and meaningful one. Focus on community rights and gender approach at all levels of programming. It's very critical when you talk about meaningful engagement. Finally, providing community-friendly reporting tools that can be accessed by those that are at the grassroots level. It's very important, and when we have friendly tools, then we are able to work on them and report using them. It's very important to engage communities, and communities are the will for us to find and to end TB. Thank you very much. These are some of the photos of activities that we support in the community and ensuring that communities are engaged in finding and ending TB. Thank you very much. Asante sana.
Hello, I'm extremely happy to be here today to represent the community of drug users at this important union conference. Uh, we know that for TPT, the most vulnerable populations right now are considered people living with HIV and children under 5. Yet, with us serving the drug community for so long, we understand that they are also a very high risk population because most of drug users in big metros are people who are migrants and homeless. And as we all know, drug users put more focus on how to get the next fix rather than what they're going to eat. So we see that they are vulnerable from the aspect of very low nutrition and also from the conditions on the streets, which are very, very unhygienic. So I am a strong advocate that drug users should be considered as an at-risk population for TPT. Right now, in our country, TPT is a term used for IPT, which is mainly isoniazid over a 6-month period. This we've seen over a period of time is not very practical for dysfunctional drug users who sometimes are in and out of drug use because relapse is a factor that we cannot ignore. And when drug users have to take something on a daily basis for 180 days, it's often that they would somehow drop out. They also have a great problem with actually finding space to even keep these medications. And this is not going to be a problem with a 12-week regimen because in a 12-week regimen, they have to take 12 doses. And communities like ours who are working with them on a regular basis, we would be able to actually monitor a 12-week dosage for our clientele. And this would make it slightly easier for them to reach completion. With this in mind, we actually offered our city TB officer to take up an operation research with us, give us 10 case studies, which would give us the data on completion rates being increased in this community. And that would be something that would help us to advocate for our group. Another aspect that we find is the PLHIV networks. They have to really be functional. In a country like India, there are some cities where the PLHIV networks are doing fantastic work. But there are some cities, and not the least Mumbai like ours, where it is absolutely non-existent. The PLHIV networks are extremely important to provide support for those who at some times not understand the need of prevention therapy because of the pill burden and because of what they go through. And they would feel that, why do I need to take TB drugs when I don't have TB? And I feel that the PLHIV networks also should be strengthened, especially those among the drug using community that we serve. And as I've said before, that TB prevention must also involve communities. Here we need to take a leaf out of the HIV prevention because we've used communities in our targeted interventions. People are used as peer educators. People are used as outreach workers. They have a sense of trust with the community and messages that go through people who've been through it before and done this in the past, they become like role models. So using the community with the prevention in terms of TPT for drug users would be a plus point as well. So we are strong advocates that community involvement should be at the foremost of our TB prevention therapy. And we also find that the drug using community are people who need support right through. We've had 3 cases of people who have died last year. These are people who had actually recovered, had given up drugs, but yet they actually went in and had DRTB, and then because of the lack of support, they actually passed away. This has really motivated us to work for the advocacy for TPT amongst our community. Thank you.